Hello, everyone, and welcome to our webinar this evening. I'm Kate from Fertility Network UK. And joining us tonight, we've got Rachel Cutting, who's the Director of Compliance and Information at the HFEA, which regulates fertility clinics in the UK, and Tony Rutherford, who's a consultant in reproductive medicine in Leeds. And this evening, we're going to be talking about embryo transfer and specifically about how decisions are made about how many embryos to put back. Some of you have sent in questions already, and we'll cover as many of those as we can. We'll do those first. And then if you've got any questions you want to ask as we go, you can put them in the Q&A box and we'll get through as many of those as we can as well. Just to let you all know, the webinar is being recorded. It will be available on our YouTube channel in the next few days, and we'll post the links on the webinar page on the website and on social media. And although it's being recorded, if you ask questions, the questions are anonymous, so you don't need to worry about that. We don't read out anyone's names, we just read out your questions. And finally, I just wanted to say, don't forget that all our services are free, but we are a small charity. And if you did want to make a small donation, that would always be very welcome. And again, you can do that through the donate button on the homepage on the website. But let's get on. Rachel, the first question I had was for you, actually, and I wondered if you could explain a bit about how the HFEA started having, why really the HFEA started having a strategy on multiple births.
This goes back quite a few years to about 2006, and at the time success rates were so much better in IVF, so the pregnancy rates and the chance of getting pregnancy was increasing. But that also meant if you had more embryos put back, then the chance of a multiple pregnancy was increasing as well. And at the time it was 1 in 4 pregnancies were multiple births. And unfortunately, with a multiple birth, although it might seem nice to have a twin pregnancy, the risks around that are so much increased. There's a higher risk of miscarriage, there's a higher risk of preterm birth where the babies are underweight or have medical and health problems. There's an increased risk of stillbirth, and the risks, well, just an increased risks around that meant that multiple pregnancy really was the biggest risk to mother and baby when you were considering IVF. So the HFEA brought together all the professional bodies, and at the time I've been an embryologist, so and Tony was the consultant, and it was great at the time because we all came together, the professional bodies, and all agreed that something needed to be done. And that's when the HFEA introduced a policy to have a target to reduce the multiple pregnancies over the years. And we're now down to a 6% multiple pregnancy rate in the UK, which is brilliant. You know, we're one of the best in the world up there with Australia and Scandinavia, really pushing the health of mothers and babies through IVF. And certainly when we first started, you know, the majority of patients were having a double embryo transfer. And we did best practice guidance, we shared that amongst the sector, and we did a lot of work to try and raise awareness. And the HFEA have just published their multiple birth report, which is accessible on our website. And it's amazing to see. It was such a nice feeling to be able to look at one graph that showed now that if you're under 35, 80% of patients will have a single embryo transfer. And even when you get to, you know, still over 60% at age 40 are having a single embryo transfer. So it's really, I think, from where we went in 2006 to where we are now, it's been a huge, you know, improvement for the safety and health of, you know, people undergoing IVF. Oh, Kate, you're on. You've just gone on.
I've just realised I'm muted. Tony, I know that a lot of people are tempted by the idea of twins and triplets, and we all know twins that are fine. And I think there's often an idea that it will be okay. I mean, what do you say to someone who comes to you as a patient and says, well, I don't mind having twins? What would your response be?
Well, I think the problem is you need to tell them the risks. And if you tell a patient the risks, then they soon realize why we're giving this advice. Over 60% of twins will be born before 37 weeks. A significant proportion of twins will spend some time on special care or neonatal intensive care units. 72% of second twins will have some perinatal morbidity, some issues related to that prematurity. So if you actually add it all together, not just the issues surrounding the birth, but then the longer term issues with twins, that yes, you're right, Kate, that 11 out of 12 couples that have twins will have two healthy babies, and they'll manage through the sleepless nights at the beginning, and they'll have their completed family in one. But 1 out of 12 will have issues with either a baby that's died, or the one that might have some handicap or has had some injury related to the preterm birth. So I think it's, once you sort of realize what the stakes are, and also I think the other thing that's important is, now that we're doing single embryo transfer, and I agree with Rachel, I mean, in our clinic now, I think we're up to about 98% single embryo transfer. And that's had a massive difference on reducing the twin rate. But what it hasn't done is reduce the success rates. And if you look at the cumulative success rates, in other words, if an embryo is good enough to have a baby, it can be frozen and it can be put back later, and you have one at a time. And so you have, just like everybody else does out there, have two babies, but they're born apart, and there's a slight age group. They may have been created at the same time, but they're delivered at a different time. And that's the safest, both for mum and for the baby.
Thank you for explaining that very clearly. Rachel, as a former embryologist, how do you make decisions in the lab about how many embryos to put back?
I think to start with, to say that it obviously the lab plays a part in that, but I think the most important approach is to have a multidisciplinary team approach, because first of all, it's a medical reason. You're the consultant, the doctor you're seeing might say you have to have one embryo transferred because of the medical reason. And then there's also other factors to take into account: the age of the patient, the amount of cycles that have had before that might not have worked. But certainly the embryology part does play an important part as well. And what we do in the laboratory is grade the embryos, look at the quality of those. And then, unfortunately, very often we don't know the actual quality until the day of embryo transfer. So it can all be a little bit rushed on the last day. You get to a blastocyst, the embryologist grades them in the morning, and it might be that you've got two beautiful quality blastocysts, and then there's a decision with the medical team, with the nursing team as well, very often. And then the decision is made with the patient to maybe put one back and transfer one. But it is a very much important, it's very important to have that team approach in a clinic where every factor is taken into account. But certainly in the laboratory, the embryologists really do grade the embryos carefully and feed that back to both the doctor and the patient, so that we can make an informed decision on what the chance of pregnancy is from the quality of an embryo.
So Tony, if the team have decided that you should have one embryo put back, but you as a patient feel that you actually want two, who makes the ultimate decision? Who decides?
Well, we've made it very clear in our documentation beforehand that this is a clinical decision based on risk. In some cases, the health authority that's funding the treatment will make it very clear that you can't have two embryos put back as part of that policy. So if you want NHS funded treatment, that will be a single embryo transfer. And that's certainly the case in Leeds. That's part of the contract that we have with the health authority. I like to think that most of the patients have been counselled appropriately before they get to that point. And having listened to our information, having listened to us in clinic, that they actually, it's the other way, Kate, they're actually rather surprised in the very rare cases where we might suggest two, because they say, well, what's wrong with the embryos? Why am I having two put back? So I think ultimately, I think if you are above 40, and particularly as you get 41, 42, you could make a case for putting more than one back. But again, what I said earlier is that if that embryo is good enough to form a baby, it will freeze and it'll survive the freeze-thaw process in over 95% of the cases, and it will be given a chance with a second transfer to help produce a family without the risk. of twins.
Rachel, working at the HFEA, do you find that all clinics make the decisions about this in the same way, or do some clinics have very different thoughts about it to others?
The HFEA require every clinic to have what's called a multiple birth minimisation strategy. And that sets out how you're going to reduce your multiple pregnancy and get to what we call the 10% target level. We can see by the report just recently, we're on average it's down at 6%. How clinics do that can vary, and they can have their own strategies, but what we're looking for is in inspection is that those strategies are effective, so that clinics are making an effort to do that. If a clinic isn't at the target and is above, we do try and work with that centre and suggest ways that they can look at their data or get help and advice from others in the sector who have done it well to bring that down. And we would look at also the patient information and think about why that multiple pregnancy rate isn't there, but it's certainly included on our inspection when we go out to clinics, and it's something that we also report on our Choose a Fertility page, which I'm sure patients would find that very interesting to look at and helps them decide which clinics to go to.
Tony, does it work the same way in clinics overseas?
It depends on where you are. To begin with, a lot of clinics, particularly in North America, would put 2 back, but there has been significant re-education and a reduction to single embryo transfers. In certain countries in Europe, again, they're even stricter than we are. The HFEA left it for us, the doctors and the embryologists, to make a decision. In the government in Belgium, for example, you can only have a single embryo transfer under the age of 40. So it's actually legislated that you can't have more than 1 put back. So I think it does vary, and there are countries, and particularly around the Mediterranean area, there are countries who will consider putting more than 1 embryo back.
Rachel, does it make a difference if you're paying privately or if you're an NHS patient to these decisions, or is it done exactly the same way regardless?
I think in relation to this question, what you've got to think about is the most important thing is to have a healthy live birth at the end of your treatment, and whether that's NHS or privately funded, the decisions about the health of your baby and yourself as a patient should be paramount. So actually there should be no difference in the decision-making process to whether you're NHS or privately funded, because it's important to take all the information, gather that together. As Tony said, some NHS contracts say that you must have a single embryo transfer, and obviously that's not the case in privately funded. But there's no reason why, just because it's NHS or just because it's privately, a different decision should be made on the health and the chance of pregnancy and getting a healthy baby at the end of your treatment.
Tony, I think from a patient perspective, there is still an idea that you're more likely to get pregnant if you put more embryos back. Is that actually the case? I mean, if someone puts 2 embryos back, are they actually more likely to get pregnant than if they put 1 back?
They are. It does depend on the stage of the embryos when they're put back. We noticed a difference when we were doing day 3 transfers. When you move to the blastocyst stage, there is still a difference. It is perhaps less marked, but what is absolutely staggering, if you put 2 good blastocysts back, the risk of twins is staggeringly high. And I think that's the risk. It's over 30%. So that's why, and the thing is that, nowadays with the, these wizards in the laboratory that can freeze these embryos so well and thaw them so well, that the majority of embryos survive that freeze-thaw process. So if they're frozen, they can come back, be put back a second time completely safely.
We had one very specific question from someone who is 28 in a same-sex relationship and ovulates, doesn't know if they ovulate naturally every month, they say actually, but they've got 8 frozen embryos, 5 top quality. It's their first transfer and they don't know whether to transfer 1 or 2. And I think what this person says is something that probably resonates with a lot of people. We don't want to transfer 1, and if it fails, think we should have had 2. And we don't want to transfer 2, and if it fails, thinking we've wasted an embryo. I mean, Rachel, what would you say to someone who feels that way?
I'm sure Tony will back us up on this as well. You know, a 20-year-old with 5 good top quality, I presume they may be day 5 embryos, really should only be having 1 back. And if you have 1 back and it didn't work, or you have 2 back and it didn't work, those embryos aren't going to work anyway. And you won't be wasting an embryo. It's just that that embryo wasn't meant to form a pregnancy. If you do it 1 at a time with those good quality embryos at that age, there should be a good chance of achieving a pregnancy, but I definitely say 1 at a time. And if you had 2 back and you got twins, they would have worked separately as well. You know, if it's going to work, it will work with 1 embryo.
That's a really good point, I think, and worth remembering. I had another question for you, actually, Rachel, because I think it's a bit of a lab type question, which was if the embryos are of differing grades, can one embryo adversely affect whether the other one will take if you have 2 put back?
So what we've got to remember, in a batch of embryos develop differently. Not one embryo will be the same. And what we do in the laboratory is keep them from obviously the day of egg collection. The next day they fertilise, and then they'll go through the cells splitting and the embryos grow into what we call a blastocyst stage on day 5. And it's absolutely normal that some embryos won't get to a good quality blastocyst at the end. The embryologist goes through and looks at them. Now, the embryos are smaller than a full stop in the laboratory. Now, there is some thoughts in research that if you have a tiny, tiny drop of culture media and you put good quality embryos together, they can talk to each other and help each other and support each other, if you like. Not everybody does that. Some people, you know, the research is it's not proven as such, but there is some thought around that. In respect to whether you put different quality embryos back into the uterus, as I said, they're still tinier than a full stop. And in effect, the uterus is quite a large place compared to a tiny little full stop. There have been a couple of studies that have shown that when you put a poor quality embryo back and a good quality embryo back, that the pregnancy rates seem lower. There's also been studies that it's shown no difference at all. The problem of those studies are they're not particularly very good design studies. They're looking backwards at data and they're comparing 2 good quality embryos against a good quality and a poor quality embryo. So I think from a practical point, I can see where it won't make a difference. I think there's more research to be done about it because, as I say, in the culture, sometimes people have said there is a benefit of putting the embryos together, but in the uterus, they're probably quite a long way apart. But there is a theory that there's so much we still need to know about the endometrium and how embryos talk to that. And it may be that there's a mechanism that poor quality embryos can't talk properly to the endometrium and they don't implant, and the endometrium doesn't let it implant. So I don't think you need to worry about that. The focus is rather than worrying about 2 embryos being put back, is having the 1 good quality embryo put back, because that's in effect going to give you the best chance.
Thanks. That's actually really interesting. Loads of things to learn from all of this, I have to say. Tony, we had a question which is a slightly difficult one from someone who'd been talking to a clinic which wasn't in the UK, where they offer reduction as part of their package, so you can put back more embryos. And they're asking if that's something that's done in the UK as well.
No, it's not. And I think it's a very risky thing to go down. And I think psychologically, if you have a long history of infertility, you get pregnant and you end up with 3 babies and you try and reduce that pregnancy down to 2, right? Then are you going to feel bad about that afterwards? What happens if it goes wrong? It's not risk-free and the whole pregnancy could be lost. It just doesn't make sense, Kate. You put 1 embryo back at and, you know, save the others for another trip out later, maybe when the child's 2 or 3, and show them where they came from, and go back and put another embryo back at that point, and have, if it's good enough to form a baby, it will form a baby later.
On the subject of frozen embryos, Rachel, we've got a question about whether it makes a difference if the embryo is fresh or frozen to decisions about how many to put back. Does that make a difference?
Tony said something earlier about how this has improved dramatically over the years, and we now use a different process from years ago to freezing embryos called vitrification. And this has really made such a difference to the survival and quality of embryos when you take them out of the freezer and use them. So as Tony said, you know, now over 95% and above, you know, nearly every embryo that's frozen at blastocyst stage will survive. And what we've seen from the HFEA data is there's actually just as good a chance of getting pregnant from a fresh and a frozen. In fact, I think last year or the year before in our fertility trends, which you can, another really good report the HFEA produces, which is on the website, it showed that actually the pregnancy rate with frozen embryos was slightly higher. So I would certainly reassure anybody to freeze their embryos and not worry, oh, I've only got 2, should I, you know, what's the risk? Am I not going to have a good a chance with that other one? Because you will. And if it's going to form baby, it will do it fresh or frozen, as Tony said.
Thanks. Tony, we've got a question for you, which is not quite about numbers of embryos, but it's about when we do a transfer. And someone's asking, is there a point where the consultant thinks that the endometrium's too thick for a live transfer and should therefore freeze the egg to wait for the next cycle?
I think that there's a very wide spectrum of endometrium that can is sufficient to carry a pregnancy. I think that we have seen, there's data from Israel which show that you can have pregnancies where the lining of the womb is as thin as 5 millimeters. I think most try and get it above 6 millimeters. It seems that the optimal pregnancy rate is between 9 to 13 millimeters, but pregnancies can still occur up to about 16, 17. If it's above 18, you begin to think, is there something wrong with that endometrium? And if there was any irregularities or cystic spaces within that endometrium, you might then defer it. But that's very, very uncommon. We don't see it very often.
Thanks. Rachel, we've got one, I think maybe for you here, and I don't know if you'll happen to have these figures at your fingertips, but I think you'll probably have a rough idea, asking about the difference in outcomes of live births for a 42-year-old, I suppose for someone in their early 40s having 1 or 2 embryos transferred. With older women, you do sometimes consider putting 2 back, don't you?
Yes, and that is again something that would be looked at with the consultant and the embryologist, and based on the quality of the embryos. Again, if you want to go back to the HFEA website, the pregnancy rates for every age group is in the fertility trends. And, you know, unfortunately, you do see a very large decrease in pregnancy rates and chance of a live birth when you get over 42, because we're thinking about the age of the eggs. And that's why sometimes over the age of 40, we do consider putting 2 back. But from the multiple births report, we can see that still 60% of women over the age of 40 are having a single embryo transfer. And again, if you've got a very good quality blastocyst and you have a single embryo transfer and some frozen, we know the frozen ones will do well. You have to think about the risks of the twin pregnancy in over 40s, because Tony probably knows more about this than me, obviously. The risks of multiple pregnancy will be much more in older patients as well. So I would say that putting 2 embryos back can be considered, but you should still consider the single embryo transfer. And if you want specific figures, go to the HFEA website and look at the fertility trends report.
Thanks. Tony, one from someone here asking how they can prepare for embryo transfer. Is there anything they can do specifically for the embryo transfer in terms of preparation?
Yes, I mean, it's good that you're as relaxed as possible at the time of the embryo transfer. You do need to have a full bladder. And I know it doesn't sound right, really, being relaxed and having a full bladder and having a speculum examination at the same time. But the more relaxed you can be, I think it's always the best if you can be that. And having a full bladder allows the doctor to be able to see exactly where the embryo is going. And it gives me the reassurance that I know I've put it in the right place. And it gives the patient the reassurance they can see it's in the right place. From an evidence perspective, the majority of women having an embryo transfer don't really need an ultrasound-based transfer, but I think it's one of those nice things that you can actually see what's going on. You can see where it ends up. But generally speaking, being nice and relaxed when you're coming in for it, looking forward to it, because there's a degree of expectation when you have your embryo transfer.
Thank you. Rachel, I think this is possibly one for you. Someone asking about having had embryos frozen quite early on day one, how many should they defrost for a transfer, as they'll need to mature them before the transfer, and asking if they can refreeze embryos. Can you refreeze embryos?
Yes, you can do that. So if they're frozen on day one, it might be that when you could talk to the embryologist as well as the clinician in the centre, and it might be that you've thawed 5 or 6. I don't know how many the patient has got. So, but certainly what we used to do, if that was a case where I used to work, is that we would thaw 5 or 6 of them out and then grow them to blastocyst and watch them develop and see which are the strongest ones there. And then if there was, say, 2 or 3 good quality blastocysts, we would put one back and refreeze the others. And we had good pregnancy rates from refrozen blastocysts. It's a different stage. They've been frozen in a different way. And yeah, there's no reason. I mean, just to thaw 2 out, if you've got quite a lot at day one, you'd be going through quite a lot of transfers to probably try and find the strongest one there. So that's certainly an option, to thaw them out in batches.
Tony, I think maybe this one's for you. Someone says, if you had a high quality embryo and had it transferred, but it didn't result in a pregnancy, was there more likely to be a problem with the embryo or the body?
That's a very good question. There are 2 things here. There is, even though the embryo looks good quality, we know from American data where they actually look at the chromosomes in the embryo and before they put them back, that not every embryo, even though it looks of good quality, is normal. So there is a proportion, and that proportion increases with age, where the embryo is abnormal and therefore it doesn't stick. And you can see even in women under the age of 30, about 30% of embryos will be abnormal, even your top quality embryos. By the time you get to 40, that proportion is increased to 66%. And it increases up to about 78% by the time you're 43. So it really does ramp up quite quickly. The other thing that the American data tells us is, even if you put a normal embryo, karyotypically normal embryo back, so the chromosomes are normal, you put that embryo back, the maximum implantation rate is between 66 to 70%. So in other words, even if you know the embryo is normal, it doesn't guarantee a pregnancy. There is a procedure-related failure rate of between 30 to 34%. It could be that the uterus, the embryo goes back, as Rachel said, it's a tiny little thing in a tiny volume of fluid. The uterus might contract and expel it. The little hairs on the cells that line the endometrium may waft it down and out. So, there's lots of reasons why it might not implant.
We've actually got another similar question from someone who said they've had 1 embryo transferred and it didn't work, and then had a 2 embryo transfer and that also didn't work, but the embryologist saying they're all good quality and wanting to know why that is. I think that's sometimes a very difficult thing for patients, isn't it, Rachel, if the embryos are all good quality? And in some ways, if you're told they're not good quality, it can almost be easier if it doesn't work, so you're kind of slightly expecting it.
I think, yes, as Tony said, we can look at, so when we look at embryos in the early stages, we just look at the shape of the cells, how even those cells are. When it gets later to a blastocyst, we look at the different types of cells in the blastocyst and we grade them, but it's obviously just looking at what that is like. There is new technology that's been introduced over the years where you use time-lapse imaging, and you can get, the embryologist can play the videos forwards and backwards, and that gives a lot more information about how the morphological quality of that embryo and how the embryo is developed. But even in the best quality embryos, we still don't know the actual health and potential of that to make a pregnancy. And there's, as I said earlier, there's so much about the interaction between the embryo and the endometrium that we don't know yet. And that's why, you know, if you've had good quality embryos back, it's really important to talk to your doctor to look if there's any further tests that might be suitable for you. As Tony said, even the healthiest embryos that we know are normal aren't going to make a pregnancy every time. And it might take, you know, 2 or 3, 4, 5 goes sometimes before you get that embryo and the endometrium at the right time to, you know, make the pregnancy.
Tony, someone's asking about the difference between medicated and non-medicated frozen embryo transfer cycle. If the clinic says this is our choice, is there any disadvantage to not taking medication? So does it make a difference?
I don't think it makes a difference overall. There have been some studies that says that you might be better with your hormone replacement cycle. Some studies have shared it might be better on a fresh cycle. The reality is it doesn't really make a difference. Overall, it's going to make no statistically significant difference. However, logistically, it can be quite difficult. And some clinics are not in a position, if you were to ovulate, or the time of ovulation was such that the embryo transfer is going to be done at a weekend, then they might not be able to do that transfer because most IVF clinics don't have as many staff working at a weekend, and embryo thawing can be quite labor intensive. So a lot of clinics don't offer frozen embryo transfers at weekends. Whereas if you do a hormone replacement cycle, it can be programmed. You know exactly when you're going to have your transfer. It's going to be in a weekday. You've got a time. You can make your commitments with your work colleagues, etc., and take time out. And so it's logistically, it's much easier to sort out with a hormone cycle.
Thanks. Rachel, someone's saying that she understands from what we've been talking about that in the UK the embryos are graded, and asking if that's the same in other countries in the EU, and also asking whether the grade of embryo is the thing that makes you decide whether to put back 1 or 2.
So a few years ago, what was then the Association of Clinical Embryologists, it's now the Association of it's Clinical Scientists, ARCS it's called now. We did some work about how to grade embryos and looked at evidence from all over the world, and then we used a system in the UK that hopefully every clinic more or less uses the same. Some clinics slightly alter it, but fundamentally it does look at the same. Now in Europe, there are similar grading systems, and there's also what's the European Society for Reproductive Medicine, that HFEA it's called, and they have guidance and develop standards as well. So every embryo will be looked at for the same things. It might be that some call the top quality embryo a grade A, some might call it a grade 1, but basically everything will be looked at the same, whether that's the number of cells that are there, the shape of the cells, there's different things that we can look at, but there's been a lot of studies done on embryo quality, and we do know when we launched the One at a Time campaign years ago, that embryo quality is really important in determining whether a pregnancy does occur. So it certainly should be a strong factor in deciding when to have 1 or 2 put back, because obviously the better the quality of the embryo is linked to a higher chance of pregnancy. In the UK, what the laboratories do here is that they actually subscribe to like a quality standard. So you have to watch videos of embryos and you grade them, and then it goes to a central place, and then you come back with a result to see if you're grading the same as everybody else in the UK. And that's a very helpful thing for laboratories to do, because it helps them see if they're grading the same as other people, what decisions are being made about those embryos. You're even asked, would you freeze this embryo? So it does bring a consistency within the labs in the UK, which I think has been a very good quality care, high standard thing to do.
Oh, thanks. That's interesting to know that everyone's doing these kind of tests all the time to make sure that their grading is up to scratch. Tony, a question we've got about embryo quality and number of eggs, which is actually quite an interesting one, whether actually if you have an IVF cycle and you end up with a high number of eggs, is that more likely to result in only a small number of medium quality embryos? And are they less likely to be successful? So, in other words, if you produce fewer eggs, are they more likely to be successful?
Not necessarily. I think that the peak pregnancy is achieved at about 15 eggs. I think the pregnancy rates, certainly in the past, were related. I'm not sure it'd be quite the same now because we're using Blasis transfer. In the days when we're doing day 3 transfers, certainly around about 15 to 16 eggs, the pregnancy rate flattened out at that stage. But bear in mind, if you have 15 eggs, you would expect 10 to fertilize. You might expect 5 to get to the blastocyst stage. There is going to be there's quite a lot of attrition, and there's a difference between individuals. And that if you've got lots of eggs, some of those might have come from quite small follicles, which will produce eggs that don't have the same developmental potential as one that's come from a larger, more mature follicle. So I think that it is variable. Everybody is different. You might get somebody who's only got 4 or 5 eggs. They have a high fertilization rate and they get 3 or 4 good quality embryos out of it. So it is exceptionally variable and it's very patient dependent.
Someone's asking a question about whether sometimes frozen embryo transfer can be better to give your body time to recover from egg collection. This person said they actually had some pain after egg collection and wanted to know whether that could affect implantation and whether sometimes it was better actually to have frozen embryo transfer.
I think that as far as the freeze-only approach, if you produce lots of eggs, and then an example of somebody who's likely to produce lots of egg is somebody with polycystic ovaries, then we now know the randomized controlled trials that if you actually freeze those embryos, create them, collect the eggs, create the embryos, grow them through to the blastocyst stage, and freeze the ones that are suitable for freezing, and then transfer them electively in a frozen cycle, you get a higher chance of a live birth. One of the theories here is that the endometrium, the lining of the womb, under the influence of really high levels of estrogen from all these follicles, becomes over advanced. In other words, is at the wrong stage when the embryo is ready to go back, the endometrium's past its best. So it's better to do a frozen cycle. In women that have a more controlled response, where you may have 10 eggs or so, there's no difference in pregnancy rates if you do a freeze-only cycle or you do a fresh transfer. So it is, again, it's dependent on the type of ovary that you have, the type of response that you have, about the decision about whether you should have a frozen effect. But just having an egg collection itself doesn't decrease the chance of a live birth.
A slightly tangential question, possibly Rachel, but someone's asking whether embryo glue will actually make their embryo stick better.
There's been various studies on embryo glue, and some have shown that there is a benefit and some have shown that there isn't a benefit. I think there was one that showed about an 8% increase in that. Others, as I say, have shown no benefit at all. I think to weigh up, some clinics use it because it's the same media suite, the same company that they use, and they don't charge extra for it. I think it's something to consider if you are offered it extra, to whether you would pay for it or not and what the cost of that is. There's certainly, if it's part of the media suite and clinics use it routinely, and you haven't got to pay for it, then that is an option to use it. It's one of those sort of add-ons that we classify as amber, that there is some evidence. The HFEA produced something called the traffic light system, and it's a hyaluronic enriched medium, it's called, on our website. So it might be worth just going and have a look at that if you are considering it, because we say we classify it as amber, that there might be emerging evidence, there is some evidence, but it could be contradictory as well.
One for you, Tony. Someone has asked, how many single transfers should a woman have before having further testing to explore why no success, and perhaps also consider having two? I mean, how many single embryo transfers would you recommend?
Well, I think that in the first instance, if you have 3 single embryo transfers and you haven't conceived, it might be worth doing some tests. There's some very exciting new research, and I stress it's research, okay? And there've been a randomized controlled trial which suggests that up to 37% of women have a different implantation window. So we're not all the same, that some people, it's better to put the embryo a little later, in others, a little earlier. And there are some tests coming forward, which have been trialed, which tries to assess that. And actually doing a personalized embryo transfer may be helpful. Now, so that's a test that you could do. Also know that the lining of the womb, that every woman has, we've got bugs all over our bodies, and we have bugs in our vagina and bugs in the uterus too. Lower levels, but they're still there. They can cause some inflammation. And we've known for some time, we did a study back in 1999, which showed that if you had a particular type of bug in the vagina it caused bacterial vaginosis, that it doubled the rate of miscarriage. So there are now some very clever tests coming online where they don't just try and culture the bugs because they're really at very low levels. They actually look at the messages that code for the different bacteria, and they can work out whether you're at high risk or low risk. Now, these are research techniques, but they are coming online, and it'll be interesting to see whether these techniques are helpful in the future. But it's certainly, if you've had 3 single embryo transfers, it's worth having a look to see if there's something that's a little different with you.
Sorry, Rachel, a question for you. Does ICSI improve the quality of embryos?
No, ICSI is there to be able to create embryos when it can't be done through just conventional IVF. So ICSI is really there for when the sperm quality, either the number of sperm that's in a sample or the number that are moving, means that if you just put sperm and embryos together in a petri dish, that they aren't going to fertilize or give a low chance of fertilization. ICSI is to get around that of male factor infertility when there's a risk of fertilization. It doesn't mean to say that it's going to create any better quality embryos.
Tony, this is quite an interesting question around women with diminished ovarian reserve, someone who's 36 but's got a severely low AMH result and was told there was only a 5 to 10% chance of success, which would normally be the rate for someone who's maybe in their 40s. So is asking about whether the eggs being younger would still be better quality and whether that would make a difference to how many you transfer.
Okay, so I think that's a very good question. The difference is that if you've got fewer eggs and you're 36, they're likely to be better quality than somebody who has a similar number of eggs and is 42. So I still think that even though you may only have 3 or 4 eggs, or you may have 2 or 3 embryos, I would still sanction only putting 1 back in somebody aged 36.
Rachel, this is quite an interesting one. What information do patients get about the possible association between the duration of embryo culture and complications in pregnancy or offspring? Is there any such data?
There's been lots of research over the years, and there have been associated risks, you know, with going to day 5 transfer. There was obviously there's lots of changes genetic at a very low level of the blastocyst as it gets to day 5, and that's something that is being looked at all the time in research. There was concern that it was maybe, there's a word called epigenetics and epigenetic diseases, and there was maybe a slight increase in that with the blastocyst. But I think considering that most of the UK now does blastocyst transfer fresh and frozen, the HFEA have got the database, I think patients can be reassured that actually it's quite a safe thing to do. That doesn't mean to say that we need more research and we need to keep an eye on what's happening. But I think mainly we can be reassured that the blastocyst transfer are working, but we still need to do some extra work. I don't know if Tony wants to say anything else about that.
I think I agree with you. I think that there is data out there about certain culture mediums, maybe, making slightly heavier babies. There's difference between different culture mediums that you use. There's so much to learn about this science. It was I don't know, Rach, was it 15 years ago? We discovered that embryos didn't like lots of oxygen. We were putting them in the same sort of atmospheric oxygen that we like. But they don't like that because they don't have that in the fallopian tube. It's only about 4%. So, once we knew that, the embryos grew much better. So there's so many things we still don't know about why an embryo and what's the best culture medium to use and what we need to do. So that's why research is so important and continues to go on. And it's why the success rates have improved over the years. I think the medicines played a part to begin with, but certainly over the last 10 to 15 years, I think most of the advances we've made have been the clever scientists in the laboratory.
And a question for a clever scientist in the laboratory, Rachel. Someone who's had one transfer which was successful and has a child, they're looking to try for a second. They've only got 2 frozen embryos left, which are blastocyst stage after the thaw. Would they be right in thinking that they would thaw them both to see which is the best quality?
No, my recommendation would be, especially if you had a successful live birth, is to thaw one out and have one replaced. Hopefully that might work. If not, wait and then in another cycle have the other one thawed and put back. If they were frozen and they were both good quality when they're freezing, there's, to have them thawed out and then transferred either two, I think that would put you at very high risk of having twins. Because what patients have got to remember as well is that it's not the age that you have the embryo transfer. So you might have had the embryos created at 32, you might be 36 now, but actually those eggs, the blastocysts, have come from 32-year-old eggs. So it's not the age when they transferred, it's the eggs. And that's the same with donor eggs, isn't it? When you have donor egg treatment, you've got to remember the age of the egg. So I would certainly recommend for a sibling pregnancy that you have one at a time.
Tony, this is something that I think patients do sometimes worry about, which is around, it's not to do with numbers of embryos, it's to do with the transfer and having a full bladder. And I know that so many patients do worry about this. They always have a full bladder for transfer, need to pee right after, and then feel anxious about this. Can you reassure that this doesn't risk the embryo being moved or lost? And would it be better to try to wait longer to pee?
Not at all. You need to go and empty that bladder. If you think about it, the embryo is going back in about 1/4 of a raindrop. It's a tiny, tiny amount of fluid, and it's put right up into the mid part of the uterine cavity, very carefully. So it's not going to drop out as soon as you go to the loo. So no, you mustn't sit there in agony with a full bladder. You need to be nice and relaxed. So go and empty that bladder. It doesn't make any difference. I think embryo transfer techniques do make a difference. And a nice, gentle approach seems to work best.
I once had a discussion with a patient about this who was very, very anxious, and I think the photos and how the uterus is put in books, it's this big just V shaped with a big empty cavity in the middle, and the uterus and the endometrium isn't like that at all. It's lots of tissue, folds of tissue that are very close together, and the embryos can nestle all in that. It's not a huge big open space that a little droplet of fluids go in. And when I explained that, we sort of were a bit more reassured about it, that it wasn't just a big space. And I think the way that it's drawn in textbooks isn't always very helpful, is it?
That's actually a really good point, actually. I'm sure that probably has quite a lot to do with it. Tony, another one for you, which again is slightly tangential, but someone asking whether it's possible to take medications like steroids or aspirin just in case you have implantation issues that haven't been discovered yet. Could they do you any harm taking steroids and aspirin?
Well, okay, there's two questions there. Firstly, about aspirin. There have been a number of studies over the years to say aspirin's this wonder drug, it's great, it increases your chances. And there have been some randomized studies which have shown that. And then there have been other studies which have shown it doesn't make any difference. And so if you look at the balance of evidence, if you put all that evidence together and analyze it, aspirin doesn't seem to make that much difference. Steroids are a different thing. I know that the Tommy's research group are looking at, this is a miscarriage research group, and they look at implantation failure as well. And they have got some very early evidence that it suggests that if you have too high uterine natural killer cells, you might have a lower pregnancy rate or higher rate of miscarriage. If it's too low, that there is a lower rate of implantation as well. So the balance is somewhere in between. You need your uterine natural killer cells to get pregnant. Now, treatment, there are no randomized controlled trials at the moment that are looking at treatment, and steroids are dangerous drugs on their own. They can have significant side effects, and they should only be taken really if there is really good evidence that it's effective. So I would certainly not sanction taking steroids as a matter of routine. If you're taking part in a research study and you're fully aware of what the risks and benefits are, and you're there to help to prove or disprove whether these treatments are effective. Because when you're introducing a treatment, the only way you can tell whether that intervention is going to work or not is to do a randomized trial. You need to give half the people the intervention, half the people a placebo, and then see what happens to the outcome. And that's the only way to prove it.
Thanks, that's a good point. Rachel, what are your thoughts on genetic testing to identify better egg quality and balancing the benefit versus the risk of damage during testing? Again, that's not necessarily about numbers to transfer, but I suppose it's egg quality, embryo quality, so it's kind of related.
Yeah, the genetic testing that can be done, as Tony talked about earlier, is to look at the number of chromosomes that are in the egg for the health of an embryo. And that's called PGTA, so it's for aneuploidy, which just basically means there's a wrong number of chromosomes in there. It's a very controversial technique and creates lots of debate across the sector. Again, there's some really good information on the HFEA website, that's on the treatment add-ons website, but it is something that we rate as red, because for a patient, for any patient just going to have IVF, this is not going to make any difference whatsoever. It will not increase your chance of having a live birth for most fertility patients going for treatment, and it can be a very expensive add-on to buy. But that doesn't mean to say it might benefit some people and for some reasons. So, for example, if you're an older patient and you've had a few cycles of treatment and had a couple of miscarriages, it may help reduce the miscarriage. So I think it's really important to discuss genetic testing with the doctor, get further information from the HFEA website. In fact, we did do a list of questions, didn't we, a few years ago, joint with FN UK, which prompts a patient to be able to ask their clinician, do I really need this? Because that's really important, because as I said, if you go on the HFEA treatment add-ons website, it is rated a red on there, that there's no evidence that it will improve your chance of a live birth just for any patient. But ask more questions about it, but don't think you automatically need to have it to achieve a live birth.
Thanks, Rachel. Those questions are actually really useful. I think they're on our website and they're on the HFEA's website. And I would urge anyone who's considering, paying for anything extra to have a look at them and make sure you've asked those questions first. Tony, we've got a question from someone who's just had an embryo transfer. They had one good quality embryo transfer this week, and so they've been in severe pain since egg collection. They've got endometriosis, but they're worried about whether the pain could affect the chance of the embryo implanting. Should they go back to the clinic, do you think, if they're in severe pain?
I think that if they've got a history of endometriosis, and I presume this is a fresh embryo transfer, they've had an egg collection and they've got significant pain, I think that it's worth getting in touch with the clinic, because they can do some tests just to see that they haven't had a late reaction to the egg collection, and that there's no infection present, because there's certain factors increase the risk of infection at the time of egg collection. And certainly if you've got cysts on your ovaries that are endometriomas, then that can increase that risk. And if you've got pain, and particularly, normally what happens is you might be uncomfortable for 2 or 3 days after an egg collection, and that discomfort should begin to reside. So by the time you come to have a blastocyst transfer, you should be feeling much more comfortable. So if the pain isn't settling after transfer, I go back to clinic and just have a few tests and get them to look at you.
Thanks, good advice. I think we've probably got time for just one last question, and I'm sorry we haven't got around to everyone's questions. Rachel, someone asking, if you only have one egg that fertilizes, would you normally have a day 3 transfer, or would you wait to see if that goes to blastocyst?
There's different thoughts on that. And if you think of natural conception, fertilization occurs in the tube, and then it takes a few days the embryo to get down to the uterus, and it's thought that it gets to the uterus on day 5 or day 6. So when we switched to do blastocyst transfer, it was thought that that was actually a better environment to put the embryo in, because it was more natural, because on day 3 it would still be in the tube, and we know that the embryo needs different nutrients at different times of its development. So it was thought a better environment to go into. So blastocyst transfer may be better, but a lot of patients might want just to have the embryo back at day 3 and not risk it getting to a blastocyst transfer. So I would look at the quality of the embryo, because there's another thought that if the embryo isn't doing very well and it's poor quality, it might be better off in the uterus, although the conditions in the laboratory have improved so much over the years. So I don't think there's a right or wrong answer. With one embryo, it can be anxious leaving it to day 5, but then at least you know the quality on day 5 and it's going into the uterus on the right day. But definitely maybe talk that through more with your clinician or the embryologist.
Thank you, and thank you both so much for joining us this evening and for being such fabulous guests and answering so many questions. I'm really sorry that there were lots of questions we didn't manage to get round to. I think we'll have to have you back again sometime and do another one, and maybe talk about, I don't know, I think one of the things that's come up a lot is around egg quality and embryo quality and things, and maybe we need to do something about that. But as I said at the start of the webinar, this will be available online if you want to view it again or share it with your friends. And don't forget that we're your charity. We're here for you. We've got groups meeting online across the UK, and our support line and our information lines are open every weekday. So do keep in touch with us. And thank you all for joining us this evening, and I hope you all have a very good evening. Thanks and goodbye. Bye.
Thank you. Bye-bye. Thank you.